So he gave more like, technical information, but we also wanted to include you as well, just to talk through, and I'll let John ask, the questions, but just wanted to kind of give you the intro and refresh your memory.
Yeah, sure.
And hello again, Doctor.
Hi.
Oh, yes, I'll see Annie's help is doing the video.
Before I give you John.
Sorry. Our videographer.
Just quickly, Doctor, I saw that you were able to move your camera.
Yeah.
So I need you to put your camera a little bit down, and I need you to go a little bit to your back, to move to your back, so we can see more of your body. Yes, that's perfect.
Okay.
Do you happen to have some lamp that could lighten up your face a little bit more? If not, it's okay. If you have, it would be helpful.
Hang on. Let me see. Brought my camera. Doesn't do much.
Okay, we tried.
These things don't actually work that great.
There, that's good.
Good?
A little bit more to your back.
A little bit further back.
Yes.
Yeah. Okay, there you go.
And the camera a little bit more down. Just a touch.
So you've been like that for a while?
Yes, and then you go, yes, there, great.
Okay.
Okay, ready, Elsie?
Yep.
And Elsie, you ready with everything? Great. Thank you, Doctor.
Thank you very much.
Thank you, Doctor. Again, last time we spoke about meningiomas.
Mm-hmm.
And this is, I guess, another class of intracranial tumor, if you will.
Yeah.
Carol spoke to us, and of course, Dr. Sioman, I believe, yesterday gave us the detail on the procedure and consulting with her about her issues with vision. And they waited, I think, about 6 months between MRIs, and they proceeded with the surgery. Can you give us, first of all, a little perspective, if you will, about pituitary adenomas or tumors? How, from your experience, how common are they, and whether they usually present symptoms, or are they usually not diagnosed unless they maybe compress on optic nerves, or like in the case of Carol? Can you give us a little perspective on
Yeah, so pituitary adenomas are one of the most common benign brain tumors. They occur in the skull base where the pituitary gland sits, and they can either be functional, meaning they secrete a hormone, or non-functional. The functional pituitary adenomas are diagnosed sooner, usually, because the patients may develop physical symptoms and signs of hormone excess. So, for example, growth hormone secreting tumors, the patient develop prominence of facial features, hands and feet. For ACTH secreting tumors that produce cortisol, the patients will get truncal obesity and wasting of protein, so muscles of the legs and arms get thinner, and they develop round faces. Non-functional adenomas usually present with headache or visual disturbance, and the visual disturbance occurs when the tumor grows up out of the normal location, which is called the sella turcica, and compresses the optic chiasm, which sits right above that region. Okay. So the non-functional tumors that present with visual disturbance, we want to protect the optic apparatus from chronic compression and irreversible nerve fiber loss from chronic compression to preserve the patient's vision. And so if there is documented growth, or there are symptoms or visual impairment signs, then we recommend surgical treatment.
Okay. And do you recall Carol's case? She mentioned, of course, the visual issues she had, which I think she said worsened over the 6-month period they were monitoring. Can you recall her case and what stood out in your mind?
Yeah, the patient had.
Doctor, I'm sorry. I'm so sorry. I need you to go a little bit more backwards. A little bit more.
Okay.
Yes. Because, yes. Okay. Thank you. I'm sorry.
The patient had intermittent visual symptoms which were non-specific but characteristic of chiasmatic compression, meaning non-formed scintillations like little flickering lights or silver specks in the periphery of her vision. And we did Humphrey visual field testing, and that was normal. So she hadn't suffered any chronic compressive nerve deficits or optic neuropathy or chiasmatic syndrome. But this is, having been in the field for 30 years, I recognize this symptom is common to patients with chiasm compression. And we were reassured by the fact that her visual field testing was normal. So we had some time we could wait and, let her decide what she wanted to do.
Are these like blind spots or?
No, they're, sometimes when you stand up quickly and you get those little white lights in your periphery, that's retinal ischemia actually.
Okay.
So those little silver white things in your peripheral vision, those are the kind of scintillating schitomata that she had.
Okay, that's the word. Yeah, okay.
Yeah.
Okay.
So it's not a fixed visual field deficit like a black area. No, she didn't have that.
And then, so about 6 months later, I guess Dr. Sioma said there wasn't really a lot of growth.
Correct.
But it was sizable as it is, I guess enough to make create these issues,
right.
Compression issues. So.
Right. So one of the considerations, there's patient factors and tumor factors. One, the patient was well, but she continued to have these visual symptoms. And because of the location of the tumor and proximity to her visual apparatus, obviously the two were related. Second thing is the tumor factor. Her tumor was big enough that there was some imaging changes which may have been early, indicating that it was outgrowing its blood supply. And when that happens acutely, the patients can have hemorrhagic infarction of the pituitary tumor, and then it becomes a big deal. Then it can be an emergency, literally.
Okay.
But the tumor was big enough with extensions to the left that we were worried that if it invaded the cavernous sinus a little bit more, we might not be able to get a gross total excision of the tumor. And so it was difficult for us to know for certain what we would find at surgery. But we were, recommending elective removal of the adenoma before it became non-curable with surgical removal.
Would you call it urgent or critical to do the surgery? Or
no, I don't think so. I think it was still an elective procedure, but the patient had symptoms corresponding to the tumor location, and there were some imaging features that were concerning, so that in her case, it was better to operate sooner than later.
Okay. And Dr. Sioma walked us through the surgery itself. Can you give us your role in the surgery? I assume your expertise in these matters helped quite a bit. So can you just give us your perspective on the surgery itself, how it went?
Right. So my job is to help, number one, the patient. Number two, the younger surgeons to promote their expertise and career. So I saw the patient and I recommended surgical removal, and I said that I would do it with Dr. Sioma, who has experience with using the intraoperative MR, which we have. And one of the biggest indications for using intraoperative MR is pituitary adenoma, skull base meningiomas, and low-grade gliomas. So there can be the occasion with pituitary adenoma surgery when the tumors are large. You think you're done, you do the imaging, and 20% of the time there's something that you've left behind. So while the patient's still under anesthesia, you can go back, look again, and make sure that you do as complete and as safe an operation as possible. So Dr. Sioman is familiar with the use of the intraoperative magnet. Therefore, I wanted him to be the principal surgeon, and we didn't have that capability back at UCSF. And so my job was basically holding the endoscope. So I was the navigator and consultant. So I give feedback about what I think is the tumor, what's the pituitary gland, where's the carotid, these kinds of things. So it works out really well. And I've been doing the endoscopics thing for 25 years, so I'm very familiar with it.
And you mentioned it's quite a team approach. Also,
John, I want you, doctor, just to make it a little bit more personal. You mentioned a couple of times the patient. Can you give me one answer? It can be a short one of your role. And you mentioned Carol's case.
Oh, yeah.
Carol's surgery.
Yeah, I didn't know whether I was allowed to use her name.
Yeah. She's giving us a testimonial as well. She's going to be part of the video.
Okay.
Thank you.
Yeah. So, we recommended the surgery to Carol as an elective procedure given the correlation between tumor location and her symptoms, as well as the concern regarding the size of the tumor and its relationships to surrounding structures. And at Carol's surgery, I was an assistant for Dr. Sioman. My role was primarily the navigator holding the endoscope for him while he used two hands to operate. And our ENT colleague provided access with the exposure and helped us with the closure.
Thank you.
And the recovery seemed to be very, very good compared to, I guess, what Dr. Sioman was saying that it could last months. I looked. It's been 3 months, and Carol said she's great. I mean, her vision's practically back to normal. I mean, can you speak about her recovery and how well? I mean, obviously the MRI, the intra-op MRI, pretty much didn't see any residue or
Correct.
any. Can you speak about it?
So Carol's case was an example of, best scenario, and that is complete removal, no intraoperative cerebral spinal fluid leak. Her recovery was very straightforward. She went home on the second day postoperatively. Because of the limited access approach with the endoscope and the lack of a cerebral spinal fluid leak, her in-hospital stay was not prolonged. We didn't require a vascularized nasal septal mucosal flap to be elevated by the ENT surgeon. And that, when you do that, the short-term side effects are more pronounced, and it affects the patient's quality of life. They have to do irrigations, etc. We didn't need to do a nasal septal mucosal flap in her case because there was no CSF leak. So it was just a very straightforward closure.
So best case scenario, really.
Yeah.
Great. And the role of the intra-op MRI really was key, I guess, here in terms of.
It was confirmatory.
Yeah.
And so it would have been the real utility of the intraoperative MR would have been if we thought we were done, we did the imaging, we found residual tumor, it prompted us to look again, and we removed the final piece. But in her case, the surgery went so well, the section was relatively straightforward. We removed the tumor completely by visual inspection at surgery and confirmed by imaging. So it was the desired result, best desired result.
In terms of these procedures and pituitary adenomas, is there a trend here? Are we seeing more of them, or are we going to be performing more at MNI, or any kind of perspective you can give us moving forward here about the importance of this type of procedure, I guess?
Yeah, so we, they're about 1 per 100,000 population in frequency. And you can do the math. If you have a population of 18 million in a state, you know that you're going to have a number of patients per year. And it is true that we need to focus on a pituitary program, pituitary center, have a team of surgeons that are doing those operations on a regular basis. High volume surgeons, high volume institutions have better outcomes. So our goal is to develop the pituitary program in collaboration with our ENT colleagues, the surgeons, and our medical colleagues in neuroendocrinology who follow the patients after surgical treatment. For those patients where we can't remove the entire tumor and there's evidence of recurrence, or we can remove the entire functional tumor and the hormones still being secreted, frequently we recommend radiotherapy. So our radiation oncology colleagues would see those patients for follow-up treatment.
And by the way, the 1 per 100,000, is that requiring surgery such as this one?
No, that's the incidence of tumors.
Okay, the incidence of tumors. And would Carol require follow-up in terms of any other therapies? Do we know at this point?
At this point, since the tumor was completely removed, the only follow-up is imaging to rule out imaging evidence of recurrence. So we'll follow her with 6 month, and annual follow-up MR imaging studies.
Great. I think if there's anything else that you want to mention about Carol's case or pituitary tumors, please. Anything else?
Yeah, I think. Well, I would say that I'm very enthusiastic about developing the pituitary program here. We certainly have the surgical expertise. We have the intraoperative technology. We have the commitment from our colleagues in neuroendocrinology and radiation oncology to participate. So I think the future for these patients is bright.
Excellent. I'm going to open it up to Gabby or Elsie-Annie.
I heard a sound while he was answering. Was the sound on your end, doctor?
Yeah, it was my phone.
Do you mind? That answer was great. Do you mind repeating the same answer, but just saying at Miami Neuroscience Institute? That way we have the name in that.
So what am I going to say again? I'm going to start over from
that statement that you made right now, that the future is bright for patients who have those tumors, and you look forward to developing the program. Just that you say Miami Neuroscience Institute.
Okay.
Enthusiastic about it, you said.
So I think pituitary tumors are common, and they require a dedicated group of individuals to care for the patients properly. So I think at Miami Neuroscience Institute, we plan to develop a Center for Pituitary Disorders, along with our colleagues in head and neck surgery, ENT, radiation oncology, and neuroendocrinology. We have the technical expertise on the surgical side. We have the intraoperative equipment necessary to do intraoperative imaging and confirm the extent of resection. And then we have the individuals who are capable of providing follow-up adjuvant treatment if necessary, and to follow pituitary function over the long term.
Excellent.
I think that was great. And then I have a quick question for you. You mentioned that the post-op intra-op MRI, was that something new that we normally didn't do before? Or I was trying to figure out what you had mentioned before.
So Baptist has had the intraoperative MR, I believe, for about 8 years. It's not been used as much as it could be used. So I've started a new pilot where we're using the intraoperative MR scan for brain tumor patients, where we finish the operation, apply the head dressing, keep the patient asleep, transport them to the magnet, do the post-operative MR scan, and then wake them up. So normally what we would do would be to finish the operation, send the patient to the ICU recovery room, and then do the post-operative MR scan the first or second day post-op. And, the MR machines are very loud when the magnetic field is alternating. So I've got to believe that it's more comfortable for the patient to be asleep when that study is done, rather than be the first or second day post-op craniotomy. So far, it's working out very well. We've increased the utilization of the intraoperative magnet, which the operating room people are pleased about. It increases the efficiency for us to be able to discharge the patients in a timely manner, rather than having to wait for a diagnostic slot on the inpatient magnet, which is very busy already. And the neuroradiology people are very pleased with us doing this and freeing up time for other imaging investigations rather than clogging their schedule with the post-operative patients. So we're looking at metrics, times, etc., and we hope to report that after a consecutive series of 20 patients.
Okay.
That's perfect. John, do you have any other questions or?
I don't think so. I think we covered everything. Unless there's anything you want to add, Doctor, but I think we're good.
Okay, good.
Appreciate your time as always.
Yep.
And your expertise, always.
Hey, Gabby,
Yes.
your background is backwards.
Is it back?
Yes.
Oh my God, but it's forward on mine.
Have to mirror it.
No, but it's left to right inverted when I'm looking at you on the screen.
You have to uncheck where it says the mirrored effect. You have to sort of uncheck that, I think.
Oh, I'm gonna do that now. But it's on when I look at my own background. I'm looking at it right. That's so weird.
I know. It does that.
I'll fix it for next time. So people don't think I look crazy. Thank you, Dr. McDermott. And Gabby,
Thank you so much.
I never even noticed. I'm so sorry.
That's why he's a surgeon.
Thank God Dr. McDermott told you. He's the only friend that told you. It's kind of like the only friend that tells you when you have a booger. It's true. Oh my goodness.
Right. Thank you.
Thank you.
Good luck.
Thank you.
Take care.
Bye.
Bye-bye.
Bye, guys.
Have a good day.
Good day.
You too.